in the field of oral and maxillofacial pathology is defined by Dr. Jerry Buku. Professor Buku holds the post of Emeritus Professor and Past Chair, University of Texas School of Dentistry, Houston, Texas. Dr. Buku has more than 445 published papers, abstracts, books, and book chapters. His work has been translated into numerous languages and has been used by state and national governments to determine oral health policy. He has co-authored the most popular textbook of oral pathology and has named more than 36 new oral diseases. It is a true honor for me to welcome you, Professor Buku, to deliver your lecture.
Hi folks, I'm Jerry Boko from the US. I was in the University of Texas and still work with them closely, but I'm also working with West Virginia University in the mountainous region just to the west of Washington, D.C. I'd like to bring a couple of weird and I think interesting little cases to you. One is a slimy sloughing keratosis, and the other I've simply called new bone above old bone. And one of my partners in crime with these kinds of cases is a good friend and wonderful oral pathologist, Ashley Clark. She, as of about a year ago, went to the University of Kentucky, where she is now the chair of oral pathology, and she was just made interim academic dean. So with that as an introduction, let us get to the case. As with everything I do, especially on an international level, I want to dedicate this to my two major mentors, Robert Gorlin at my old University of Minnesota, and Jens Pinborg, who was kind enough to take me on as his fellow for a year in Copenhagen, Denmark. So now we can start the cases. Case one, you will see from the case one screen here that I have a kind of a quirky sense of humor, but these cases really do fit with that those weird eyes staring out on the left-hand side of the screen. They're interesting. They've not caused much harm. This one hasn't caused much harm to the patients at all. But the first case that I'd like to present is from a 27-year-old woman who has for 6 years been experiencing what she called peeling skin of her mouth membranes. It's been primarily on the non-keratinized tissues of the vestibules, a little bit creeping up onto the keratinized tissues. And she described it over and over again as slime. And this has a history of starting out as a gray plaque, slowly getting thicker and more white. And then after 3, 4, 5 days, it turns slimy. And at that point, she can peel it off with her fingers or washcloth or whatever. And she does that routinely about every 5th or 6th day. And then she has 2 or 3 days free of any problem, and it all starts over again. And you can see where the arrow is pointing on the left-hand picture, where I have already taken my thumb and just pushed up on the side and peeled it up forward. And on the right-hand picture, I've taken this a little further and pushed it up more, and you can see that it has exposed a pretty normal underlying mucous membrane. Well, she had already been through, she also had a second area of the opposite side of the mouth in the maxillary vestibular area, and as the lower right picture shows, I have pushed against it sideways, just gentle pressure with my thumb, and you see how easily it's peeled off with no really adverse effect on the underlying mucosa. Well, she had been to many, many doctors. She'd been through the antifungal, systemic, and local. She'd been through antibiotic, systemic and local. She'd been through corticosteroids, local and systemic. So she had been around the mill, and nobody had ever bothered to do a biopsy or even a pap smear of this lesion. So I had seen it before about 9 previous times, and I kind of knew what it was. So I suggested that we do a cytology, and the next slide shows what the cytology was. The cytology was entirely 100% pretty intact thickened layer of perikeratin here. In other areas, as in this small piece, there was orthokeratin, but primarily in all of my cases, it's been perikeratin. And you can see this is a fairly fresh, thickened layer of keratin because we don't have much bacteria, we don't have candida, we have no really degenerative changes. It's just fresh keratin, and it's on a non-keratinized surface, so it shouldn't be there at all. So we can't call it hyperkeratosis, we can call it keratosis. And it looks like it's sloughing off. My guess would be that it's sloughing off from the immediate bottom of the keratin layer, but only a biopsy will prove that. And she was willing to let us do a small biopsy to show what is what. And the biopsy showed a little bit of inflammation, a few lymphocytes down in the underlying stroma, but these are two areas of the biopsy that showed in this top picture on the right. It's mostly orthokeratin in this site, and you can see it's been peeled off very cleanly. It takes a few of the cells from the underlying keratinocytes, but not too many really. And it has a little bit of retention and almost sticking to points here and there, but primarily it is peeling away or lysis of a thickened keratin layer. And of course, you know, and from our dermatology literature, we all know that this is called the subcorneal acantholysis. So it's more than that. It's in an area that should not have keratin at all, and yet it does. So it is keratosis. And so I think a good term for it would be subcorneal acantholytic keratosis. Now in the skin, that is seen not as a unique lesion, but as part of other things like psoriasis. There's a pemphigoid version, and a few other skin diseases show this kind of subcorneal peeling away. There is one called subcorneal acantholysis, but it's got three terms, and the middle term is pustular. And we have no pus, we have no inflammation other than these few lymphocytes in the underlying stroma. So that's not in the picture here. And I don't think anybody really understands what causes that either, and we don't know what causes this. Therefore, I decided that the best name for this, and you might disagree or agree, would be idiopathic subcorneal acantholytic keratosis. And nobody, very few of us, unless you want to really impress people, will spit out four big names, but it very nicely shortens up to Isaac. So I've been calling this Isaac for many, many years. I called it SAC for a while before I added the idiopathic. And it is nothing more than a somehow induced keratosis, maybe hyperkeratosis of some of the attached gingiva. But it's a thickened layer of keratin that peels off painlessly, leaving a normal underlying mucosa. That's essentially my definition. And I don't think we have to do biopsies anymore of this. The first case that I saw is in this lower picture. She was a 12-year-old girl, so we were thinking epidermolysis bullosa and a few of these kinds of things. I saw her with Bob Gorlin, and he could come up with nothing. We peeled it off, and we had that same keratin layer. She was the worst example I have seen out of the 10. And that's because she had the thickest layer of keratin, and it took a couple of weeks for her to develop to the point where she would peel it off and then it would all start over again. She also had, you can see, a little bit of redness beneath the surface once it was peeled off, but that went pink in a very short time. And since we couldn't figure it out, we did biopsy this, and this is an old slide that I found. An old photo mic that I found of this. It's mostly perikeratin, as you can see, and it's pulled away from the underlying epithelium, leaving a little bit of maybe some of the keratin layer, but mostly it's peeled away directly from the underlying less pancake-shaped cells. So that was my first case, and this is my latest case. And the only thing that I think we have to worry about is to make sure it's not white sponge nevus, because some of those have peeling lesions. Most of it does not peel off. And microscopically, we see a bunch of intracellular edema. And the intracellular edema I've not seen in any of the cases of Isaac. So the other possibility would be, you've all seen this in people who use an excess amount or even not an excess amount of toothpaste or mouthwash or material, paste-like material for whitening the teeth that has a strong ability to do this, and microscopically it does have extra keratin. It does have subcorneal acantholysis, but it also has that intracellular edema, or etching as the Europeans used to call it, puffed up white cells in a superficial part of the epithelium just under the keratin. So histologically, it's different, but of course, it's easy enough. Before you give the name of Isaac to a diagnosis of Isaac, you'd have to rule out whitening toothpaste. And I have done it by just asking the patient to use just plain old water to brush their teeth with for up 2 weeks to up to a month. And in my cases, that made no difference whatsoever. So the other cases that I've had, they've been either in the vestibular mucosa or the oral floor or the lower lip. A few of them were on buccal mucosa. They tend to be a little more keratotic because of cheek biting in that location, but otherwise they all look very, very similar. And the one of these on the oral floor was a friend of mine who's a dental hygiene faculty in my school. And so we had plenty of time. You can see what 110 months of total duration and follow-up. And it didn't change at all. And we tried all kinds of things in order to stop it. So this is a never-changing, innocuous thing. It's more of a pest. People have to peel off slime. But I think it's definitely a distinct entity. If anybody has any cases similar to this, I'd appreciate finding out about it. Maybe we can add it to our list before we send it off, our paper off to publication. All right, so getting on to case 2, that's a whole different ball game. It's not mucous membrane at all. It is beneath the mucous membrane. And these are little chunks of bone, or at least calcified material. We have been finding these. It was pointed out to me by myself and my chair, who's also an oral pathologist. It was pointed out by a dental student who was, I think, in his 4th year at that time. He's now a part-time faculty member, but his name was Yusuf. And so once he pointed it out in his case, in an urgent care patient, we started to see it everywhere. And I think we've got 40 or 50 examples of it now between the two of us. And I went back to through my old biopsy system, and I found 2 cases, this one from 1992 and an earlier one from 1989. This is the a larger one, so I'm presenting this. You see blocks or angular chunks of calcified material, a little bit smaller piece down here. And I don't know if this is an aggregate of calcified snow beneath the mucous membrane, but it all seems to be above the periosteum. And I have noticed in almost all the cases, the bone, the crestal bone of the of the alveolus doesn't really look very nice and smooth, but we do see that quite frequently, even without these submucosal calcifications. And the question, of course, is this a submucosal calcification or ossification? And that's why it was important to get these 2 biopsies previously, because we didn't want to go ahead and biopsy ethically. It just didn't seem to be proper, because these were producing no problem at all. However, back in 1992 with this patient, a 21-year-old female, it was tender to palpation, so there was a reason to remove it. But the primary reason was, you see how thick the mucous membrane is here. They were going to put a Pontic in between these crowns, and they wanted to have it a little bit lower, so they wanted to have this mucous membrane cut out. And that was done, and microscopically, it turned out to be bone. And you can see on this lower picture, the low-powered one, that there's a lot of normal, pretty, maybe mostly mature, a little bit immature collagen, moderately dense to dense fibrous collagen tissue. There is no periosteum here. There's nothing. It's just normal submucosal subepithelial stroma. The bone is pretty immature. It makes a little attempt to become cancellous or lamellated, but it's pretty immature. And I've seen this in many of my bone marrow samples in people with ischemic damage. And so I've learned to call this stagnant new bone. I don't know a better name. And this looks pretty much like it. I think this is bone that was able to be created, maybe because there were some little periosteal cells that got ripped apart and got tucked under the overlying epithelium at the time of extraction. This particular lesion, it's been 7 years since a tooth was extracted. So this has probably been around for many, many years right now. So it's new bone that was able to be formed and mature a little bit, but unable to really remodel fully into true mature cortex type of bone. No big deal, but it is bone. It is created, I am convinced, above the periosteum. And if it's bone, we can either call it ossification or ossificans. And I think ossificans is the more correct term if we're following the medical literature. There is, of course, myositis ossificans. And in medicine, they use ossificans also for bone formation in ligaments, in fatty tissue, in fascial planes. So it's not just confined to striated muscle. So the name that we decided to give this, other than Yusuf's bone, which I seem to use more than any other type of name, is it's descriptive, supraperiosteal ossificans. There is in the orthopedic literature, there is an entity called periosteal ossificans, but it's something like Gary's osteomyelitis, and some people use it as the new term for Gary's osteomyelitis. With Gary's osteomyelitis, as you know, you have an underlying chronic kind of festering low-grade osteomyelitis, and then the cortex gets perforated and stimulates the periosteum to lay down this onion skinning type of bone, or sometimes it's more random like we have in our particular example. But this is still above the periosteum, so it's different. And we don't have any biopsies of any bone, underlying bone. Our assumption is it looks a little funky. It looks less dense than normal. Many cases have shown that. And it looks like it has a ragged top, so it's not a smooth cortex. But we don't believe this is a periosteal reaction based on those two microscopic cases that we have. So supraperiosteal ossificans, new bone above old bone, I think is a good terminology. We have presented this at a couple of national meetings, but and we're in the process of working this up. So if any of you have anything like this, and I think once you're aware of it, you'll start seeing it everywhere. You have to turn off the overhead lights or go into a dark room and enhance these views digitally. But I think this probably, according to Brian, who's in urgent care all the time, I think Brian estimates that maybe 1 out of every 40 edentulous sites has this kind of bone. Not as prominent as this, but it's there. So these are just some other patterns that we've seen. A linear pattern, just like an onion skinning. This is a C-shaped or seashell-shaped pattern found on a cone beam. And then there is the snowflake pattern where it looks like we've got a bunch of augmentation material. But in this case, it was biopsied, the implant was taken out, and it was bone. It was all new bone. It wasn't old cadaver bone or bovine bone. And we don't have access to that particular microscopic picture. And it's often very, very subtle, as you see in this lower middle picture. And in addition to the angular case, the lamellar or linear case, or the C-shaped pattern or the snowflake pattern, there is this globular pattern in the lower left picture. And some of them, the other biopsy has less dense background fibrosis and less bone maturation and less osteoblastic activity. So there is a little variant, little variety associated with this. And those that are not very darkly white or bright white are probably, the bone is there. It doesn't seem to be dystrophic calcification. It's actual bone, but it's immature bone, so it's not as calcified as we normally would find. And just to point out, now with especially cone beam that has a much larger field of radiographic interpretation, a recent paper found that but almost a third, actually exactly a third of all patients who've had cone beams have had some kind of soft tissue calcification picked up. And in a little over 1%, 1.5% of these cases, we have bone being formed either just beneath the skin, osteoma cutis, or in the muscles of mastication, myositis ossificans. So now we have a new variant to look for. This particular case did not find anything. I don't think they were looking for it, but they were probably looking for anything abnormal. So this is just a new entity that has to have a little more information known about it. So that's all for now. We've given you a slimy sloughing keratosis and a new bone above bone, old bone. And okay, take care.